Okay, my second topic is ultrasound-guided liver ablation for hepatic dome lesion. Fortunately, this is an 18-minute single video, so feel free and relax my video. So objective is clear, but the real practice is not quite easy, very complex. So I think there are many kinds of the complex factors to achieve the best result of hepatic dome lesion ablation. So I like to, this talk will be a good opportunity to understand how to ablate for hepatic dome lesion, mostly in Asian country. So ablation is already accepted as one of the curative treatments in the many treatment guidelines because of the many technical achievements and clinical experience. What does matter? Tumor size and location and conspicuity and aggressiveness still matter. But today I like to focus on more location, among them, more focus on liver dome lesion. Why hepatic dome lesion is difficult to ablate? Because, as you can see, a tumor usually cannot be visible on ultrasound, and also there is a possibility of a thermal injury. If you want to climb the Himalaya, we need to a proper preparation. Invisible and adjacent diaphragm. That's the problem to achieve the best result. If you cannot see the tumor clearly in ultrasound, there is a possibility of an incomplete ablation. If you ablate too enough adjacent to diaphragm, we can suffer from thermal injuries. So accurate placement is essential for complete ablation. Safe always should be first because ablation is the most minimally invasive treatment. Balance between the complete and safe ablation is really important, but sometimes very difficult. We have to catch the two rabbits. For accurate targeting, we can use the CT or MR or ultrasound as a guiding modality, but I don't have any CT guidance experience. So today I'd like to focus ultrasound-guided ablation for hepatic dome lesion, including position change and fusion and contrast means ultrasound and artificial fluid. For avoiding complication, if you do percutaneous thermal ablation, we should use artificial ascites or artificial effusion depending on tumor location. And also we can take the more conservative strategies, including the less power and away from the diaphragm. And if you decide to don't do percutaneous thermal ablation, there are so many alternatives, including non-thermal ablation, cryo, and ILE. And also we can choose the alternative approach, laparoscopic or open approach, on or alternative treatment combined with TACE or radiation therapy. So there are so many options. So don't worry too much. Okay? Depending on your situation, you can choose the proper weapons. We can completely cure. There are so many ways to climb the Himalaya, but as far as I know, there is no one golden rule. There are so many routes. So there are so many literatures to prove the safety and completeness of hepatic dome lesion ablation, but there is no sufficient evidence which way is better than the other. Like this, there are so many ways to climb the Himalaya. So don't insist one way. So we don't need to be like a Prusa. Just we can choose the proper weapon depending on your situation of your institution or your experience. Today I'd like to focus on ultrasound-guided ablation for hepatic dome lesion. This is a summary of how I do for liver dome ablation. I do planning ultrasound for all patients referred to percutaneous ablation. In most cases, I use fusion, and sometimes I add contrast lens ultrasound with EUV MRI. If the conspicuity is fair or poor, at that time I add CUS. After using all kinds of fusion and CUS, I cannot be sure whether tumor is located or not. At this time, I refer to combined treatment TIS plus ablation. The incidence is about 5 to 10% in our institution. So that means more than 90% of cases we can ablate completely but safely using the CUS and fusion imaging technology. Microwave ablation with artificial ascites. This is a small 1 centimeter metastatic tumor in subcapsular segment A. Very close to CP angle. This is how to prepare artificial ascites for hepatic dome lesion. We use 5 French angiography sheaths rather than spinal needle. Many more operators just use spinal needle, but I strongly recommend angiography introduced sheaths has a much benefit compared to needle type. We use a BP cuff to infuse more rapidly. Our operation is not so much big compared to the University of Beijing. But big difference, we prefer the angiography introduced sheaths rather than spinal needle. And then, on ultrasound after fusion, we can see as we can expect, the lesion is barely seen on ultrasound due to overlapped round shadow. So to improve Sony window, we have to use artificial ascites. So for skin anesthesia, to minimize intercostal bleeding, the skin stick. Dilate for 5 French sheaths insertion, like angiography. I insert the sheath needle towards the peritoneum, and then I instruct the patient a little bit inspiration. At this time, liver is downward displacement. At that point, I insert liver capsule 1 centimeter with sheath needle. After I instruct the patient full expirate, usually the tip of sheath is placed in the peritoneal space. At that time, I insert guide wire and change the dilator. It's very simple. If you have experience of angiography, I strongly recommend to make artificial ascites using angiography. You can see the sheath, the narrow space between the capsule and liver, peritoneum and liver, and change the guide wire, sheath guide wire, 5 French. It takes just 3 minutes, I think, so we can invest the time. After remove the 7 French dilator, you can see the 5 French sheath, the peritoneal space, right subphrenic space, not subhepatic space. And after full dripping up to 1 liter, you can see the separation of the liver from the peritoneum, as well as the conspicuous lesion is getting increased. This is the one that clear reason to use artificial ascites to improve Sony window. You can see here such a tiny tumor, 1 centimeter tumor, so we can insert accurately like this. Without artificial ascites, it is impossible, I think, such a 1 centimeter tumor. And then it's time to insert applicator. At this time, I use the imprint. Okay, there's a tiny calcification, the metastatic tumor. I just insert a little bit away from the center because it's a very small tumor. And already we separate the liver surface from the peritoneum. We don't worry about thermal nature. And then I set the tumor size, and the yellow line is the circle is the goal of ablation volume, okay, including 1 centimeter ablating margin. This is a useful tool. You can use any kind of ultrasound machine. And to be sure, I add contrast lens ultrasound and finally check that this is the index tumor. This is my purpose for ablation. If the ablation zone is over this red area, I stop even the 3 minutes and start 5 minutes ablation. A lot of echogenic bubble from the outside of the tumor. And during the ablation, we should monitor closely to be optimal. Okay, the ablation zone is covered, the tumor itself, and approaching the anterior ablating margin. So don't worry, the thermal ablation, because of artificial ascites. Okay, it's time to remove the electrode. So this is our one study. If you use the sonazoid, we can decrease the popping phenomenon definitely. But there is not enough data, but you can try. The popping phenomenon is source of peritoneal seeding and transvascular seeding, but if you add ablation, the sonazoid, the instance of popping is definitely decreased based on my clinical and experimental study. And cauterization, there is no bleeding and along the tract. So we have 2 small holes. Compared to even laparoscopic ablation, this is really minimally invasive. We only use the 1 bandage, less than 2 millimeter bleeding. Okay, pre-ablation MRI and post-ablation, so considering contraction is enough ablation. The second case is RFA with artificial pleural effusion. There is a 2 recurrent tumor in segment 7. The artificial site is not effective in this area. In this case, we use artificial pleural effusion. Tumor 1 and tumor 2, pretty big. For making artificial pleural effusion, we use a semi-erect position to minimize the amount of artificial fluid. Using just a 300 millimeter will be enough in this position. We use 17 gauge epidural needle rather than spinal needle or the angiography sheaths because the amount is very small, 200. So approach the CP angle on ultrasound, this area, and approach this area. If the tip is placed in the pleural space, usually pleural cavity is a negative pressure, the fluid is automatically dropped. That point is a pleural area. So just 1-2 minutes later, you can see we can move this kind of pleural lung parenchyma upward. The 500 millimeter enough. Okay, you can see the artificial pleural effusion. The region conspicuous is better, and we can protect the diaphragm as well. Okay, first ablation using the multiple radiofrequency ablation, and then move the superficial area and ablation again. We don't drain out the pleural effusion. Usually automatically observe the pre and immediate after ablation. You can see the really enough ablation. I think a little bit excessive, but anyway. Okay, this is how to make the safety for hepatic lesion artificial ascites, artificial pleural effusion. If there is a post-op state, we can use the hydrodissection or the tumor-aborted gallbladder. Okay, bare area, so we should use artificial pleural effusion rather than artificial ascites. We cannot separate. So this is our feasibility map. The dome area is quite difficult, this area, that we use artificial ascites. 7 area, we use pleural effusion rather than artificial ascites. Another case for bare area, very tiny tumor in segment 7, bare area. An ultrasound barely seen, but if you use artificial ascites, we cannot separate it here. Definitely thermal damage. So we use artificial pleural effusion, lesion, and ablation. So not feasible or failure for thermal ablation, but we have many solutions: fusion, artificial fluid, and contrast enhanced ultrasound. So to climb the Himalaya is really difficult, but if you have preparation, we can do with safely and completely. Fusion, effusion, contrast enhanced ultrasound. Hepatic dome lesion is not so easy, difficult, but we have good friends: fusion, contrast enhanced ultrasound, artificial fluid. I think that's why I'm here. Thank you. So let me introduce our ABSOM 2024, which will be held in May next year. So please come together and enjoy the solo day. Thank you very much.